Real life.
Good evening, everyone. Welcome to iFocus Online, lecture number 555, Optics and Refraction, module number 30. Today we have Dr. Arvind Kumar Morya, sir, who will be talking on prescribing monofocal, bifocal, and multifocal lenses. The moderator for today's session is Dr. Prajakta Dandekar. Ma'am is faculty in Cornea and Anterior Segment Services at Shantilal Sangvi Eye Institute. She is a former Lieutenant Colonel Indian Army Medical Corps. She is a qualified para jumper in 2011. Ma'am has received the Chief of Army Staff Commendation Card in 2012. She has completed fellowship in Cornea and Anterior Segment from LVPEI. Ma'am has numerous publications in national, international journals, including book chapters. Ma'am expertises in cataract, ocular surface diseases, and corneal infection. We welcome you, ma'am.
Thank you so much, Dr. Kaveri. And thank you. I thank the Center for Sight platform for iFocus. It's great to be here. Thank you.
The chairperson for today's session is Professor Monica Chaudhary, ma'am. Ma'am is a retired senior optometrist at AIIMS Delhi with over 39 years of experience. She is director at Monica Chaudhary Vision and Eye Care Clinic, Gurgaon. She is also founder of Learn Beyond Vision, an online teaching platform. Ma'am expertises in contact lenses and specialty lenses, myopia control and orthokeratology, low vision rehabilitation and vision therapy, pediatric eye exams, and amblyopia treatment. Ma'am has several awards and honors under her belt, to name a few. Shri Award in Delhi Citizen Forum in 1999, Australian Leadership Award in 2012, Global Best IACLE Contact Lens Educator Award in 2015, Asia Pacific. She has several publications, 5 books authored, including Contact Lens Primer, Low Vision, Refraction, and Lens Prescription. We welcome you, ma'am. The speaker for today is Professor Dr. Arvind Kumar Morya, sir. Sir is providing cataract, glaucoma, refractive, squint, pediatric ophthalmology, and medical retina services in Hyderabad, India. He is heading many projects based on artificial intelligence on diabetic retinopathy, glaucoma, and amblyopia. Sir has numerous national and international presentations and publications. Sir is also section editor at IGO, editorial board member EC Ophthalmology, DOS Times, UKJOS, and various other ophthalmological societies worldwide. He is international faculty at SIC, SSO, WOC, ICO, ESCRS, and White Knight. Sir has several awards, to name a few. First Indian to win Ophthalmic Star Award at Amsterdam, ESCRS 2021. First to receive AIOS Senior Academic Achiever Award 2021 and 13 Oration Awards. Social Enterprise of the Year Award 2023 by AI All India Institute of Ophthalmic Society. He has several international and national state level awards as well, more than over 120. We welcome you, sir. Over to you.
Thank you, Dr. Kaveri. Thanks for such a nice introduction. Dr. Kaveri, shall I start?
Yes, sir.
Is it full screen now?
Yes, sir.
It's showing, sir.
Yeah. So, a very good evening. Just a second. So, thank you so very much. iFocus, Dr. Maipal Sachdeva sir, Dr. Santosh Unawad, Dr. Prajakta, and a special thanks to Dr. Kaveri for giving the opportunity. So, my talk is on prescribing monofocal, bifocal, and trifocal multifocal IOLs. So, we all do cataract surgery, and these intraocular lenses are need of an hour, and I have no financial interest with the subject matter. So now coming to the short history of intraocular lens, so it was first implanted for the treatment of cataract, was implanted by Sir Harold Ridley, FRS at St. Thomas Hospital on 8th of February 1950. So whenever we look for an ideal premium IOL, so what should be the ideal qualities in that IOL? So it should be dysphotopsia free, no photic phenomena like the halos, glare, and the starburst, ability to correct distance, intermediate, and near vision, and it needs to be cost effective also. So now coming to the photic phenomena, which are the halos, glare, stardust, mostly seen with the multifocal intraocular lenses. Why? Because these multifocal IOLs are designed to focus light at different distances. So some light is always falling on the retina, that is always slightly out of the focus. And then there is this diffractive technology to split light that also leads to glare and halos formation. Pupillary size can also affect the severity of glare and halos, as larger pupils allow more stray light to enter the eye and leads to photic phenomena. Poor quality of the tear film. The most people, the gradual improvement over time as their brain adapts to the new intraocular lens after implantation of the multifocal IOLs. Uncorrected astigmatism, the residual astigmatism, this also worsen the optical aberrations and contribute to glare. Posterior capsular opacification, that is a cloudy secondary membrane behind the IOL, can also lead to additional light scattering and glare. Now coming to the negative and positive dysphotopsia. So the causes is the unwanted optical images which are seen by the patient. So the positive dysphotopsia is a bright artifact of light described as arcs, streaks, starbirds, rings or halos occurring centrally or mid-peripherally. Negative dysphotopsia is the absence of light on a portion of the retina described as a dark temporal arcing shadow. The positive dysphotopsia include the shape, size, index of refraction, and material makeup of the intraocular lens. And these positive dysphotopsia occur when an external light source is present, especially when it is located obliquely at approximately 35 degree. The rounded edge of the intraocular lenses disperse the stray light over a greater area of the retina, resulting in less positive dysphotopsia. A high index of refraction has also been implicated as a causal factor for the development of positive dysphotopsia. Now coming to the negative dysphotopsia, so the causes are they occurs more frequently in women in the left eye and within the bag intraocular lens. And the focal cause as an illumination gap is seen when the pupil is fully dilated beyond 6 millimeter of the optic of the intraocular lens. There are multiple studies, so it is more prevalent with thick rather than thin intraocular lenses. As per the study by the Muscat et al., the reverse optic capture fashion, thus causing anterior shifting of the illumination gap and reducing this negative dysphotopsia. Acrylic intraocular lens as well as high positive angle kappa values and high IR values, they also leads to negative dysphotopsia. Horizontal inferotemporal haptic orientation, this also minimizes the negative dysphotopsia. And there is definitely a central nervous system component with the negative dysphotopsia as per the study by the Muscat et al. Because they observed 80% reduction in the negative dysphotopsia scotoma when the contralateral eye was occluded. Now coming to the poor contrast sensitivity, so it is good with the monofocal IOL, but when we are opting for the bifocal or the trifocal IOL, so it reduces. Why it reduces? Because after multifocal IOL implantation, it is primarily caused by the design of the lens itself, which splits light into multiple focal points, leading to reduced contrast in the focused image due to the out of focus light that is also reaching the retina. Now coming to the depth of focus. So lot of patients, they are undergoing keratorefractive procedures. But when these patients are going for the cataract surgery, we are seeing a lot of refractive surprises. So it is the freedom in the values in the diopter to get crisp and clear distant vision, especially in the post-keratorefractive patient. So this is how it is done. So any IOL which has a full range of this depth of focus between plus 1.5 to minus 3.5, so that is 5 diopter power of the depth of focus. So even if the dioptric power during the biometry is wrong in any patient, still the patient will have the crisp and clear vision between 6 by 6 to 6 by 6 part. But it is anywhere between plus 0.25 diopter plus minus 0.25 diopter to 1 diopter in most of the intraocular lenses. Now coming to the crisp and clear image quality at the retina, that is the modulation transfer function of any intraocular lens. So in monofocal IOL, they have a significantly higher MTF value at distance vision, indicating better image quality and contrast at a single focal point. Whereas in the multifocal IOL, they have lower MTF across various distances due to the need to distribute light for near, intermediate, and distance vision, resulting in reduced image quality at each focal point. Smaller pupils, they improve the MTF of a multifocal IOL by reducing the light scatter. MTF evaluates the ability of an optical system to transfer the spatial frequency with high fidelity as seen in this graph. Now rotational stability. So most of these IOLs, they have the foldable IOL, they have modified C-loop design. So in this diagram, you can see only a few millimeter of this modified C-loop is in contact with the capsular fornix. So that's why there are theoretically and also chances, practically also chances of rotational instability. Now coming to the focusing ability of IOL. So first is the unifocal, the monofocal intraocular lenses, that is the lens with monofocal power. But they have ability to correct the distance vision. So they have problem, they are not able to correct the near vision. Now coming to the design and material, in short, so square S design, surface modification, UV absorbing material. So the chromophores are added, which are of two classes: hydroxy benzophenones, the hydroxyphenyl benzotriazoles, and the biocompatible material. So the IOLs have UVL compatibility as well as the capsular compatibility, and the material is bioactive. Now coming to the aspheric intraocular lenses, so human eye, they have aspheric optics because the cornea has positive spherical aberration, and the young crystalline lens, they have negative spherical aberration, so they negate and neutralize each other. Whereas in the aging lens, cataractous lenses, it gains positive spherical aberration. Now coming to the need of the multifocal IOL, so restoration of accommodation in pseudophakia. So methods are, if we are using the monofocal IOL, so micromonovision can be done in one eye for distance vision and the other eye for the intermediate or the near vision. And then there are multifocal IOL and accommodative IOL. Coming in short, the history of multifocal IOL. So Hoffer in 1982 was the first to hit upon the idea of a multifocal intraocular lens after observing a patient who had 6 by 6 vision in spite of an IOL that was decentered by more than 50% of the pupillary area. But it was Dr. John Pierce in 1986 who was to implant the bullseye style of the multifocal intraocular lens. So this is the bullseye design of the multifocal IOL. So you can see distance vision for daytime driving, and then near vision for moderate to low light condition, and then near vision for the full range of light conditions, Also, distance vision in moderate to low light condition, distance vision for night driving. So there is a continuous zone transition providing intermediate vision also. So these are the simultaneous vision lenses. Design can be either refractive or diffractive optics, and pseudo accommodation is needed. So they have multiple focal points in the intraocular lens, the refractive type of multifocal intraocular lenses. They have, in this diagram, you can see there are multiple focal points. Now coming to the material, so initially a silicon, then the acrylic, and then the acrylic are in vogue. Then comes the design of the diffractive multifocal IOLs. So for the near as well as the far focus. So distance vision, you can see white arrow, it is for the distance vision, and near vision you can see with the blue arrow. Now difference between these refractive versus the diffractive intraocular lenses. So refractive has excellent intermediate and distance vision. Diffractive has excellent reading vision, and the near vision is fair but may not be sufficient to see very small print in refractive multifocal IOL. The diffractive IOL, they have fair intermediate vision, and in the diffractive type of design, the patients who read for prolonged period of time or in poor lighting may experience eye fatigue in the refractive type of IOL, but they are pupillary independent. And patients who do lots of computer work, intermediate vision, so they are very happy with the diffractive type of the IOLs, and they are less pupillary dependent. But they have disadvantages that we have already discussed, like the reduction of contrast sensitivity, glare, halos, starburst, less satisfactory visualization of fundus, difficulty in the post cataract surgery, diabetic, or the other vitreoretinal procedures. They requires neuroadaptation. They requires accurate biometry because they don't have the broad range of the depth of focus, precise and well-centered intraocular lens implantation, and also astigmatic reduction. What are the principles of these multifocal IOL? So single IOL with two or more focal points, so types refractive, diffractive, or it can be a combination of both types. So there is concentric rings of different powers. So first is the two-zone lenses. Then the second design is the annulus type of lens or the bullseye lens that we have already discussed. The two-zone lenses, so there is a central near vision segment surrounded by the distance vision segment, and the central section is 2 mm in diameter as the pupil constricts during near vision. And when pupil dilates during distance, viewing peripheral distance segment is exposed. Disadvantage is during the bright sunlight and poorly tolerated by the patients who enjoy or prefer outdoor sports. Coming to the principle of the trifocal. So the IOL utilizes the principle of diffraction in conjunction with refraction to create two foci. So basic refractive power by the anterior surface and the diffractive power comes from the multiple grooves on its posterior surface. Most of the time, 40% of the light is focused for distance vision and the another 40% is focused for near, and the remaining portion of the light for the higher order of diffraction, that is for the intermediate vision also. As this lens has a diffractive optical effect present at all points of the lens, even if the lens is decentered or the pupil is eccentric or deformed, lens will always supply power for distance as well as near vision. Therefore, diffractive IOLs are pupillary independent. Now coming to the few newer generation presbyopia correcting intraocular lenses. So this is the Bibinagar geometric trifocal optics. It is designed to provide a full range of vision. That means distance, intermediate as well as near vision. So what is different in this? So because of the light distribution, near addition is 3.5 diopter, intermediate 1.75 diopter. So it has two types, Bibinagar geometric. So the range of vision in the far for the distance vision, excellent, intermediate, very good, and fair or good for the near vision. Whereas the light distribution is altogether different. In the geometric plus, it is excellent for the near vision, good for the intermediate, and very good for the distance vision. So now you can see this is the light distribution. So you can see in geometric plus, the light distribution is more for the near, and whereas in the geometric plus, the light distribution is more for the distance vision. So now coming to the optical bench contrast comparison. So it is almost 0.55. Ideal needs to be 100%, but even with the best of the monofocal, it is between 70 to 80%. So it has 55%. Again, defocus is very good. So these are few of the data. So very in 97% patients very happy, excellent distance vision, and intermediate is again 98%, and 86.5 and 11.2 they had the near vision, Jaggers near vision between n by 6 to n by 8. So 86% of the patients were spectacle free for all types of vision. Now coming to the satisfaction rate, so 95.5% were highly satisfied. Again, this is a newer design with zoning in the intraocular lens, Clearview 3 by LensTech US, and July 2022 FDA approval. So you can see a near optic 3.0 diopter add-on on the anterior surface. So it has zone transition. It doesn't have the refractive or the diffractive type of rings in it. So it is a non-concentric ring refractive multifocal IOL designed to improve contrast sensitivity, minimize dysphotopsia like the halos and glare because there are no rings and zones, and provide superior near, intermediate, and far vision as compared to other presbyopia correcting intraocular lenses. The segmented asymmetric optic design is the first of its kind. The LensTech's patented 4-point fixation and design allows surgeons confidence in the IOL's effective lens position within the capsule, and it's available in 0.25 diopter power increments. So these are as per the first study. So the uncorrected distance visual acuity. So most of the patients, they were very happy, 90% of the patient. Then the intermediate visual acuity, again, the patients were 90% of the patients were very happy. And the near visual acuity, again, the 90% of the patients were happy. Now coming to one wonderfully designed Make in India polyfocal progressive autofocus intraocular lens. That is the world's first polyfocal progressive IOL. So it is, you can see the design, it is a little bit different. It is oval. Horizontally, it is 7.5 millimeter, a larger optic. Vertically, it is 6.3 millimeter. And the loops are the modified zigzag shaped L-shaped design. You can see it is not that typical modified C loop. It's a L-shaped design with achromatic zigzag shaped. You can see these achromatic, right? So whole this 6 millimeter of the L-shaped haptic is in contact with the capsular fornix. So it provides more rotational stability. And our team did the first world study. So it's published in Clinical Ophthalmology. You can read in detail. So how it corrects the distance, intermediate, and near vision because of the patented GRIN technology. What is GRIN? It is gradient refractive index. So it has two superior holes. So it needs to be dialed in the superior part. The two holes needs to be in the horizontal, in the superior part. In the superior part, the refractive index of this IOL is 1.42, which gradually increases to 1.54. And by this GRIN technology, it has the wonderful ability to correct distance, intermediate, and near vision without any concentric rings. Now coming to again the comparison that we have already discussed. So why this IOL doesn't have any dysphotopsia? Because the horizontally the large size. So even in the highest mesopic condition, when the pupil dilates more than 6 millimeter of the optic, still the IOL optic it covers. So there is no confusion over the retina because there is no 10 to 20 degree of the aphakic area present nasally or temporally. This is the dilated slit lamp picture, and you can see the difference in the lower. You can see there is 10 to 20 degree of the aphakic area, whereas in the autofocus pro IOL there is no gap, and that's why there is no halos, glare or dysphotopsia. So according to our team's study, we compare both the IOLs. So both the IOLs has excellent ability to correct the distance vision. Yeah. Yeah. So coming to the intermediate visual acuity. So we compared it with the ICRL bifocal multifocal IOL. So as expected, as is doesn't have the ability to correct the intermediate vision. So it was the patients were not happy with the intermediate vision, but with the autofocus pro IOL, almost means 99% patients were very happy with their intermediate vision. So the 90.2% patients had a good I6 vision and the remaining had I8 vision. Now coming to the near vision, again it was slightly better in the autofocus pro IOL. 91% of the patient N6 and the rest of the patient has N8, whereas 85% with the ICRL multifocal they had N6 vision, 11.3 had N8 and rest of them has more poor than N8 vision. Depth of focus. So no IOL in the world as we did this. So we were really astonished to see the result. So the ICRL had 1 diopter plus minus of the depth of focus, whereas the autofocus pro IOL has an excellent depth of focus between plus 1.5 diopter to minus 3.5, just like a teenager. So even if the IOL power or the dioptric value is wrong during the biometry, especially post-keratofractive patient, which we are going to see in the coming decade a lot. So those patients will be able to see the vision, their distance vision will remain between 6 by 6 to 6 by part. Contrast sensitivity, again, it was better with the autofocus pro IOL. Photic phenomena, none in autofocus pro, whereas 34% in the multifocal observed the photic phenomena. Now, why we need to prescribe different patients, different types of IOL? So it can be a monofocal, or it can be a bifocal, multifocal, or it can be a trifocal, because we are dwelling in a competitive world, and competition is the best form of motivation. And cataract surgery is now treated as a refractive surgery. So patients have very high expectation. Their expectation is so high that they want to see better vision as they were able to see during their teenage life. Ideal premium IOL, we have already discussed. I'm again repeating, free of negative dysphotopsia, free of photic phenomena, cost effective, and ability to correct distance intermediate as well as the near vision. So why the necessity beyond the monofocal IOL? Because change is the only constant. To remain competitive in the market, to manage the high patient expectation and proper education, and also whenever we are starting a new ophthalmic setup, so there is high EMI, and those EMIs they are not waived off even in situation like COVID, which was a recession for the private practitioner. The visual function is beyond the Snellen's or the Logmar chart. It depends on the ocular surface disorders, the degree of astigmatism, type of lens, retinal health, optic nerve health, contrast sensitivity requirement of a particular patient according to their profession, healthy visual access intracranial, and the patient perception of vision. So there is importance of counseling whenever we are dealing with any patient who is undergoing cataract surgery. So right choice for the right patients. Astigmatism needs to be less than 1.25 diopter. There needs to be a vision questionnaire. That means what is the requirement of a particular patient. History of previous keratorefractive surgery for high dioptric correction, unhealthy retina and ocular surface, any other ocular pathology like the diabetic retinopathy, ARMD, or glaucoma, type A, fussy patient, or the patients who want to become the super eye heroes after cataract surgery, night drivers, or the patient who demand high contrast sensitivity and modulation transfer function. So these patients are ideally fit for monofocal IOL. If they want some degree of spectacle free for the intermediate vision, we can go for micro monovision, in which one eye for distance and the other eye for the intermediate vision. And also during the counseling, I often discuss the expenses of spectacle per year. So it is anywhere between 5,000 to 10,000 per year. So this also we can explain while we are counseling the patient. Recommendation needs to be realistic. All options for the patient from monofocal, EDOF, or the bifocal or the trifocals, and well informed with no hiding clauses, and because it is the key to assess patient for a particular intraocular choice. It is the most important aspect. And always under promise and over deliver whenever you are about to means implant these bifocal, multifocal, or the trifocals. Always says that 20 to 25% of the patient they might require some degree of spectacles. And ensure with positive attitude, honest information needs to be fed, best suited IOL for a patient, and always look for higher order aberration, and also high angle alpha and kappa needs to be considered. And acquiring the right technology. So we need to have in our armamentarium good optical biometer for accurate IOL power calculation, topography and tomography for corneal assessment, checking for irregularities and measuring astigmatism, OCT for detailed retinal or macular evaluation, and aberrometry to assess higher order aberration, and surgical equipment, access to advanced phacoemulsification machines, and potentially a flags for bladeless surgery for enhanced precision and safety. The art of patient counseling is always a savior. So invest chair time in educating patient about the pros, cons, potential side effects like the glare halos and the cost. Set expectation, understand potential compromises in vision, that is slight loss of contrast sensitivity. It needs to be a team approach. Empower the entire clinical staff, the technicians, counselors to be knowledgeable and consistent with patient education. So same knowledge needs to be fed at each level. The knowledge needs to be same uniform. It must not be ununiform. And informed consent needs to be taken. Documentation is required. Detailed written informed consent, especially for patients with borderline indications. Now coming to the surgical pearls and post-operative management, surgical precision. So a well-centered, appropriate size capsular axis, astigmatism management, address astigmatism using toric IOLs or the LRIs, post-op care, meticulous post-operative management to address any residual refractive error or the complications, and there needs to be always a plan B for managing unhappy patients, which may involve spectacles, contact lenses, or IOL exchange in rare cases. So there needs to be a customized approach, affordability, imported IOLs for the richest or who can afford. I have no financial interest. So these are the companies which we can opt for. And those patients those patients who cannot afford the imported IOLs, so we have very good the IOLs by the Appasamy Care Group Orolab. So in my experience, bifocal multifocal IOLs for the female housewives Who doesn't want to drive? No computer work and affordability. Trifocals, professional requiring spectacle-free vision for all types of vision, that is distance, intermediate, and near vision. Who can afford the trifocals? Little compromise on the contrast sensitivity and the modulation transfer function. They needs to be well aware. Photic phenomena. They needs to be mentally prepared. Easygoing patient with healthy ocular surface, cornea, and retina. And this is a small algorithm. So no spectacle independence, monofocal, spectacle independence, full time or part time. So EDOF. So again, this is how we decide regarding which patient to undergo which type of intraocular lens. So in conclusion, so success in all practice relies on expertise, advanced technology, diligent patient selection, and excellent communication. And the future lies in latest IOL designs like new EDOF lenses, light adjustable lenses, and surgical techniques. And exceeding patient expectation leads to satisfied patients and practice growth through word of mouth referrals, which is highest capacity in any type of advertisement. It carries 150 to 200 times more value as compared to any other type of advertisement, that is word of mouth referrals. And my humble request for my candidature for AIOS ARC South position. Thank you so very much for giving me the opportunity. These are my acknowledgement, the innovators of the Autofocus Pro IOL, and my family, my parents, my patients, my staff. Thank you so very much.
Thank you very much, sir. It was an excellent presentation. We have one question in the chat box. Dr. Ashisha is asking which IOL would you prefer for yourself?
I will go for Autofocus Pro IOL
Yes.
because it is photic phenomena free and no dysphotopsia.
Yes. And
I
sir,
have already
any yes,
implanted in my mom's eye bilateral implantation with high angle alpha and kappa. She was a high hypermetrope, so very happy my mom now and spectacle free.
yes. Sir, and any specific choice, like for multifocal IOLs, in case if you have to prescribe it in a laser vision, already the patient who has undergone laser vision correction.
Yeah, so in such patient we need to how should I stop sharing?
Mm.
I'm not able to do it.
Can the tech team help in this?
Yeah, tech team kindly make it stop sharing.
If you open your Zoom, there is an option of stop sharing on the top.
Stop sharing. Showing option of share, not of stop sharing. Okay, I will close it. Uh, is the screen visible? Yeah,
Yes, now it is.
yeah. So in keratorefractive refractive post, it's a big challenge whenever the patient comes to us and demand for a spectacle-free vision because they are used to it after the very good, excellent surgery. But we need to be very cautious because so there are options in the optical biometer for the patient who has undergone the laser visual corrections. So we can opt for those options, but still, even after doing all this, they might end up in some refractive surprise. So again comes the savior, that is counseling. Even the King Khan, Shah Rukh Khan had a refractive surprise. We all know that.
And any Indian multifocals, sir, which you recommend
Yeah,
for
Autofocus
affordability?
Pro, we have implanted in 12 patient who has undergone the keratorefractive procedure. So they are very happy with it because it has that excellent depth of focus that I have discussed in detail. So even if our biometry is wrong by 4 to 5 diopter, so the patients are happy. Their distance vision is always in the range of 6 by 6 to 6 by 6 part. Any
And
question
about
from the audience
any,
also? Professor Narendra Taneja
yes, sir.
sir, Professor Suresh Raman Rao.
Dr.
Congratulations.
Suresh is asking, sir.
Yeah.
Very, very good presentation.
Thank you, sir.
Dr. Suresh is asking, is autofocus a multifocal or a trifocal IOL?
No, I told specifically it is a world's first polyfocal progressive IOL. Its technology is patented green technology. There are no refractive or diffractive rings, and there is no posterior surface truncation or the posterior surface apodization like the other trifocals and the multifocals. So the green technology is there. Superior part 1.42 is the refractive index that gradually increases to 1.54. So it's just like these progressive glasses I'm wearing.
Mm.
It's a
And
polyfocal progressive IOL.
any residual error you prefer? Like it is at 0 or little myopic?
Yeah, so I always opt for plus 0.25 diopter. Suppose the diopter power came at 20.25. So I will go for 20.5 for best results. Little bit,
Yes.
yeah. Yes, Toric Autofocus Pro, yes, within 6 months, that version will be available. As per my conversation with the innovators, Dr. Jagdeep M. Kakadia, Dr. R.C. Shah, and Dr. Satish Dishit. Within 6 months, the Toric version will be available. Yes, Dr. Vikas, any question?
Very nice presentation, sir. Good
Thank
evening.
you.
Sir,
Good
Autofocus
evening.
Pro is Autofocus Pro has the advantage in post LASIK patient, RK patients, because if you put any diffractive in these, they have a lot of higher order aberrations. So that in that case, it is very forgiving.
Yeah,
Autofocus
it
Pro,
is. It is.
especially
Yeah.
because the diffractive rings, any diffractive IOL, that will create much more higher order aberrations. Even your biometry, keratometry is correct and up to the mark.
Yeah.
Thank you, sir. Thank you. Very
No,
great
no
presentation.
other intraocular lens which is providing a multifocality
Exactly.
has this MTF value of 70%. No other IOL.
Exactly. No other eye.
Yeah.
Exactly. Very nice, sir.
So there is a question by a student.
Yeah.
What is the role of angle kappa and angle alpha in choosing IOL and why?
So whenever it is more than 0.7 and more than 0.3, we must not, because the centration is required. If these premium IOL are not well centered, then it leads to the decrease in the vision, and the patients are the most unhappy patients. So whenever these patients have more than 0.7 and 0.3 angle alpha and kappa, so in such patient we must not implant the premium intraocular lenses. This is the limit. If it is below 0.7 and 0.3, the patients, the IOL will be well centered, patients will be happy. But a decentered IOL, so that leads to unhappy patients because the centration is very important whenever we are implanting any premium intraocular lens. Thank you for using the Autofocus Pro. I have no financial interest. Yeah.
Sir,
Yes, Dr. Vikas.
one thing I would like to add in these days, today's era, always I think a patient should be counseled about the dysphotopsias
Yes.
because sometimes, even with the best 6/6 vision, patient is very frustrating. Sometimes their dysphotopsias they don't go because there are cases the brain doesn't adapt and neuroadaptation failure. We can say
Yes. Yes.
in at least 5 to 10% of cases, the brain doesn't adapt to the refractive design, particular design. Preoperatively we should always counsel the because as you said this is going to happen. The patients who had LASIK in the 90s, they will now come
Yes.
to in the next decade they will come for cataract surgery or even
Definitely.
press myopia surgery because they that time they didn't like the glasses, so the mentality remains same. So they will, when they will have press myopia now, they will come for to you for surgery to us ophthalmologists. And then it's a big challenge because without cataract, we are operating them just because of spectacle independence. And they are the highly challenging patients for
Yes, they are.
presbyopia correction.
They are. So
Yes,
there is
yes.
one question in the chat box. Uh, FDA approval. Which IOL? If you are asking about Autofocus Pro, yes, it is CDSCO approved as per the approval by CDSCO DGHS Ministry of Health and Family Welfare since August 2019, which was renewed in 2024. So it is the government approved IOL since August 2019. And you can see online going to the CDSCO website, all the documents are uploaded there.
If there is any more question, please feel free to ask.
So coming to the dysphotopsia, so why it is happening? So I will again repeat why it is happening, because most of the optic size is 6 millimeter. So in the highest mesopic condition, that is between 6.75 to 7 millimeter. So there is 10 to 20 degree of the aphakic area, as I have shown in my presentation also in the slit lamp picture. So that aphakic area, when the stray light are going into the retina, that causes confusion over the retina, and that leads to confusion and leading to dysphotopsia. And as per the systematic meta-analysis published in the JCRS, the Journal of Cataract and Refractive Surgery, as rightly said by Dr. Vikas Gupta, 10 to 12% of the patient, they will have complain of this dysphotopsia, even in the monofocal intraocular lenses also.
If there are no more questions, then I guess we can wrap it up.
But sir, mostly these dysphotopsias, they go with time. Just to
Yes,
explain to the patient that they will go your surgery. And about negative dysphotopsia, what is the good thing is that if you have implanted it in the lens, in the bag, capsular bag, you can very well say to patient that your surgery has been very perfect. And this is the another sign in negative dysphotopsia that your surgery is okay. So just
yes,
reassurance to the patient. And I think 3 months or 3 to 6 months is the adequate time. And if it does not go after 6 months, then you can again give some time up to 1 year. And then after any you want to do any ND or capsulotomy, don't do if you are planning for a IOL exchange in case of negative dysphotopsia, because then the surgery becomes difficult of IOL exchange. That becomes very
yes,
difficult if you have done ND or capsulotomy laser, and try to postpone it as much as possible. But I think because the lens will become adhesions, we become so very judiciously you have to manage the time. I think what recommendation is that 6 months you can wait for neuroadaptation, but you have to just think of fibrous adhesions that will dwell between the lens and the capsular bag. So
yes. Most of
depending
the
on that, because
patient,
then
they adapt to it within 3 to 6 months.
yes sir, yes sir.
Dr. Monica, ma'am, your concluding remark? Our chairman is here in the meeting.
She was online.
Okay. So what are your experiences, Dr. Prajakta, whenever you are choosing any patient, particular IOL, particular type of patient?
Yeah. Sir, about dysphotopsia, I had one point that, like in cases of dysphotopsia, also sometimes it is confusing with those when the patient is 20/20. But I realized that we should rule out cystoid macular edema also. In many cases, it is because of CME and we blame it on the IOL.
Yes. So thorough examination, OCT is a must. And again, importance of the counseling. So in 3 of my slide, I discussed regarding the counseling part.
There are two things also I will like to mention. Sometimes there are posterior capsule stria, not
Yes,
opacification. that will lead to a dysphotopsia. You have to examine carefully in the slit lamp. And in the fundus, if you have a epiretinal membrane, which you have earlier missed, that will also decrease the patient vision. Mostly six patient, they are problematic, frustrating because of two things only: dry eye and dysphotopsias. So after doing the careful slit lamp examination and fundus examination complete, and you have to rule out VMT, vitreomacular traction. Is there any vitreomacular traction? Because that will lead to flashes of light. The
Yes.
difference between positive dysphotopsia and flashes of light is that due to VMT, that the positive dysphotopsia will only occur when the patient will सामने से कोई light आएगा तेज reflector light, then he or she will be having only positive dysphotopsia. It never happens in the absence of light. The basic thing is, I think, the oblique, when the patient will have oblique light coming from
Yeah, 35
reflector,
degree. 35
at
degree.
least 35 degree. Exactly.
You would like to add something, Dr. Narendra Taneja, sir?
Sir, I have experienced that the vision is best. If you are suppose a surgeon or eye surgeon, you must not go for you must go for monofocal only, because
Yes.
the quality of vision decreases if you go for EDOF. I underwent EDOF lens in one eye, and then in other eye I had monofocal plus. So if I compare my both eyes, the vision is better with the monofocal plus, and as compared to the EDOF eye.
Definitely,
And
sir. They have high contrast perception, as well as the reading speed, as well as these modulation transfer function is always better in monofocal.
and
Sir, what is your
this dysphodopsia, they, if you happen to travel on a say 2-lane road, and if you are traveling on a 4-lane road, so I realized when I was going to Bhatinda and I was reaching Bhatinda and it was a 2-lane road, then I realized that dysphodopsias are there in the id of 5, not
Mhm.
in the other.
sir? What is your practical experience with the EDOF hybrid multifocal IOLs? EDOF hybrid, they are coming in market. A lot of EDOF hybrid IOLs.
I have experience of implanting iHands from J&J. I again repeat, I have no financial interest, and the patients are very happy because they are not totally dependent on specs. At least for intermediate vision, they are totally specs are not required. Only for near vision, whenever they need that near vision work, that time only they require those glasses. So
No, sir,
iHands,
EDOF hybrid multifocals like Symphony. Symphony is a EDOF hybrid multifocal.
yes.
So can we mixing and matching of lens, like first eye we put a EDOF hybrid and in next eye trifocal, so that patient has complete spectacle independence for
That
distance need.
experience I don't have, but in 18 patient I have experience. They were implanted the different type of the trifocal intraocular lenses by Alcon and by J&J and Zeiss. In the other eye, we implanted Autofocus Pro IOL with this
Okay,
addition of plus 0.25 diopter, and they were very happy.
okay, sir.
Yeah, so that mix and match we have done.
And what IOL you will prefer in a like mild AMD patient, like dry AMD, and can we go for a multifocal or trifocal lens in that case?
If it is very mild type of dry RMD, of course, along with no ocular surface disorder, we can go for the premium IOL. But if it is extensive, even a dry type of ARMD, I will opt for a monofocal.
Okay, sir.
Yes. Yes, Dr. Shashank, you would like to add? Unmute yourself. Unmute yourself.
Sir, good evening, sir.
Very good evening, sir.
सर ये व्हाट अबाउट स्पाइरल आइवल्स, ये रेनर के जो आए हैं
Yes.
स्पाइरल आइवल्स, इनका सर क्या एक्सपीरियंस है सर?
So I have implanted only two. It is AI based spiral sort of design instead
Okay.
of proper refractive rings. So still those two patients, they were complaining of some degree of halos and glare. Photic phenomena were there. Whereas the Rayner people, executive were saying that it is free from the photic phenomena, but those two patients did complain of some degrees of halos and glare.
Mhm.
But it is very
And what about
less
vision?
sample
Vision in
size.
that patient, sir?
Vision was good. Vision was good,
Okay.
but the halos and glare, they were there. So, but it is a very less sample size.
Yes.
So, it is not conclusive. We need a larger sample size, multicentric study. It's a new IOL in the market. So we need to wait and watch, look for the Indian data and their publication. Then only we can rightly comment. It's too early to say anything.
Mhm. I have used about 6, 7 IOLs,
That's great.
spiral. So
Right.
patients are satisfied,
Okay.
not complaining anymore. It's a
Yes,
good
they are
IOL, I
very
think.
happy with the types of vision, but
Yeah.
the photic phenomena is still there.
Yeah.
Yes. Professor Suresh, sir, you would like to comment anything?
I asked what's the material used in Autofocus Pro?
It's two types of material are there. One, the hydrophilic is 50% hydrophilic and 50% hydrophobic. This acrylic material, and the totally 100% hydrophobic, again acrylic, preloaded, 100% hydrophobic. That goes with the 2.4 millimeter incision. And
Okay,
it is
thanks.
anti-glistening.
Yeah.
Anti-glistening
Okay, thanks. And are there any additions on the lens?
means addition.
Means you do you so is light enhancing and for the light and the chromophores and
No,
those
no, no.
things?
It's
Nothing.
no chromophore. It
Nothing.
is no chromophore.
Nothing.
It is yes,
Just a simple. Okay.
transparent white.
Okay.
That uh,
Okay. Thanks a lot.
yeah.
Good.
Dr. Ramya is asking whether can EDOF lens be used in macular dysfunction?
EDOF. So the counseling needs to be proper with the patient. So the preferable is monofocal. If the patient want that some degree of spectacle free, that option can be given, but still I will go for monofocal.
So not in every patient, EDOF lenses or monofocal plus lenses, they do not provide any intermediate vision. Like in my, and I have felt myself, I had IHANS in one eye and the Lux Smart in the other eye, and none of the eyes I have any intermediate vision.
Right.
Only I have only with glasses I can see.
Yes, sir. Even with the best of the premium IOL, I said in detail regarding the total spectacle free vision is not possible. Whenever I am counseling any patient, I always say that 20 to 25% of the time you might require some glasses for the intermediate and near vision. So our counseling needs to be proper. No IOL can be 100%. Let's see the light adjustable lenses when they will come to India. So wait for that IOL.
Okay, sir. Thank you very much, sir, for
Thank
your
you.
very nice presentation, and
Thank you,
hope
sir.
you will be elected as member ARC South Zone.
Thank you. Thank you so very much. So thank you so very much, Dr. Kaveri, Dr. Prajakta Dandekar, for giving me the opportunity. Thank you so very much, Dr. Maipal Sasdeva sir, Dr. Santosh Onawar, for starting this such great PG program, the iFocus online, and making us part of it. Thank you so very much.
Thank you. Great
Thank
talk,
you,
sir.
sir.
Thank you.
Thank you.